Today, we have a very, very special program. This program has been specifically designed to help you to understand the rationale, the logic behind some treatment options that we have in complex cases. Complex cases, specifically Edentulous, can be treated in different ways, some more traditional ways, some more not so traditional ways. And what we did today was, because we understand and we acknowledge that there are a lot of people, a lot of colleagues that are not really comfortable with some of the new solutions, and therefore we invited a panel of experts that will present to you the way they treat these cases. So the way we've done this is that each expert will show you a case and give you information on the case, and then they will present to you the way or the options they have to treat this patient. Now you then vote. You vote on the options. The options will be numbered from 1 to 5, and then you vote on the options through a gadget that you have, and Steve will explain to you later. After voting on the options, then the expert will show you how they did the case and the results. And it would be nice to see how many of you followed his rationale and how many of you followed other rationales. This is very interesting to know. At the end of this panel, you can use the gadget also, not only to vote, but to ask questions. At the end of the panel, the gadget is the event app in the phone, if you can check your phones. At the end of this session, we will have some discussions where I will take the questions from the audience and I'll place the questions into the panel to discuss. So, to start and to explain to you how you can vote and ask the questions, I invite Stephen to come to the stage. Stephen, please. Stephen is the IT guy. I know nothing about IT. And Stephen will explain to you how this works. Stephen, some of the people are deaf, so you have to use your hands to explain everything. Yeah?
No problem. Okay, good afternoon, everybody. So as Paulo mentioned, during the course of this session, you're going to be asked a series of questions. To send us your answers, you need to enter the event app. You need to go to the More item in the bottom menu, and then enter the polls section. Each question that they ask will have a separate poll. You simply need to go in, select your answer, and submit your response. Afterwards, the results will be displayed on the stage, on the screen. And then finally, as Paulo mentioned, at the end, you'll be able to submit questions. To do this, you need to enter the session item in the agenda. In the top, you'll see that there's a section called Activity. If you're the first person to ask a question, you need to select Start a Conversation. If someone's already asked a question, then you need to use the pencil icon in the top right-hand corner of the screen. Okay, happy polling?
I hope they understood all that. And we will see by the number of people voting and asking questions if the audience actually understood everything. So, without any further ado, I would like to invite the panel that we chose to be here today with us. Let's invite the panel up. Good. So this is the panel of experts that we chose. And you are welcome to ask all the questions through the app and we try to fry them with those questions. So we have Anna that will present the solutions available for Maxilla Edentulous medium bone density. And then we have Glen that will present us a solution for the mandibular. And then we have Enrico will present us solutions for Edentulous maxilla, medium resorption, but soft bone, which is, as you know, a problem. Soft bone and lack of bone is always a problem. And then we have Andrew that will present us solutions for Edentulous highly resorbable mandibular. And then finally we have Ruben that will present us solutions for the Edentulous maxilla highly resorbed. So I would start with the first one. Anna, please, could you take the stage and show what you have?
Thank you, Paulo. So I'm very honored to be the first one to share my case with you. And I'm going to share the case of Clara. I've known Clara for 14 years now because she works at a restaurant that I go every day for lunch. So finally, after these 14 days, Clara had the courage to come to me and say, you know what, Anna? I would like to have confidence in my smile again. So she's a relatively young patient, and she has no systemic disorders, but she has a high smile line. When you look at Clara, you see that besides the roots that she has teeth decay in the roots of the canines and incisives. So, besides this, she has a crossbite in the right side, and it's considered to be a terminal dentition in the upper jaw. Going to the intraoral situation, we can also see that besides this, we have lack of space available in the area of the second quadrant to do a proper rehabilitation. We go and we check the radiographic analysis. By the radiographic analysis with the OPG and the CT scan, we realize that we have a lot of bone. We have about 5 millimeters of bone height in the area of the first molars. So now we come to the treatment options. Which treatment would you choose? Now it's the time to grab your phones. So treatment option 1 would be to place 6 straight implants, being the posterior implants in the area of the first molars, shorty implants. Option 2, grafting with autologous bone, and then 6 or more implants. Option 3, grafting with biomaterials, bilateral sinus lift, and then 6 or more implants. Option 4, the all-on-4. And option 5, zygomatic implants. So please take your time and vote. I am going to guide you through the rationale of my solution to rehabilitate this case. So when I go to the radiographic evaluation, I see that I have the bone available for all these solutions. But as you know, we do not need only bone to place our implants. We have to understand that patients want more than implants. Patients want proper teeth. So it's crucial to have a good clinical evaluation, which means then when I look at Clara, I see that she has a high smile line, which means that if I do not do anything about this smile line, I will see in the future the transition zone between the artificial gingiva and the natural gingiva of the patient. And another thing that is also very important is to understand how much do I have in terms of prosthetic height to do this rehabilitation. So I know that on the second quadrant, I lack this space to do a proper prosthesis. So I come to the conclusion that I will have to do some bone reduction. So what do? I go to my DTX studio and I start to evaluate what I can do after removing the teeth, after taking some bone out, which means I will reduce about 5 millimeters of bone. How much bone will I still have available to place my implants? And the thing is, when I start to remove these 5 millimeters of bone, I have no bone anymore in the posterior area. I have about 0 millimeters in the area of the first molar. I have about 2-3 millimeters in the area of the second premolar. So I start to plan. Is it possible to go to the all-on-4? Is it possible that by tilting my implants, I'm able to come to a good solution on this case? And this is exactly what I planned. So I placed 2 posterior implants in the back, normal standard implants, 4.3, the parallel CC implants with 15 millimeters of length, and in the front, 13 millimeters of length. So I check with my planning, and I'm happy with this planning. So by this time, you already know the treatment choice I have. So I go into the surgery. So how does the surgery go? Well, first of all, we go and we extract all the remaining teeth, the remaining roots, we clean all the infection, and we make an incision on the crest with 2 release incisions in the area of the first molar. We open a full thickness flap, which is crucial, so that you can see all the bone available that you have. After this, we are going to reduce the bone. You can reduce it using the rounder, you can reduce using the burr, but it has to be controlled. You have to make sure that you have reduced the bone that you have planned. Afterwards, we go to the midline. We do a small osteotomy in order to place our guide. It will be our GPS during the surgery. After this, we start with the posterior implants. So we start with the posterior implants in the back, and in this case, I had medium bone. So this means I'm going to prepare my implant site preparation according to the bone density that I have in order to achieve a good primary stability. So in this case, to place a 4.3 millimeter diameter implant, I drilled with the 2 to 4 to 8 till the end, and then the other 2 drills on the cortical. So I place my tilted implant, then I compensate the tilting of my implant using my abutment, and after this, I move to the other side and do exactly the same. Now, what we have to think about is always what type of bone do I have? And here, it was enough just to go for under preparation protocol in order to have a good primary stability of my implants. So after placing the posterior implants, I go and place the anterior implants, connect my abutments, and after this, I will suture everything and do a fertilized impression. So fertilized impression is crucial so that you have an accurate model for your prosthesis. After this, more or less 2 hours after the impression, I am able to give to Clara a proper fixed prosthesis. And this is exactly what I have done. A full all-acrylic prosthesis just 2 hours after the surgery. So this is exactly how Clara looks like. In resume, just to say, the treatment option was the all-on-4. The implant choice were the Nobel Parallel CC. And here you can see the OPG. So this is the OPG after the surgery. This is how Clara looks like. And as you can imagine, she's very happy. Now, why did I go with this treatment choice and not with the others? Well, basically, when we treat edentulous patients, we have several goals that we want to achieve. And these goals are the goals that make us every day trying to get better and better. So I want to allow my patients immediately to have teeth in the same day of the surgery. I want to deliver a fixed bridge with high quality and aesthetics. I want to do everything in one surgery if possible. I want to avoid more complex surgeries. I want to avoid bone graft. But of course, I want a simple surgical protocol and also a prosthetic simple protocol so that more dentists like you be able to provide this treatment to your patients. Of course, it's needed training and education, but it's a simple protocol. Of course, I want a protocol that has high success rates, not only immediate high success rates, but I want high success rates long term. And for that, it's mandatory to have a good hygiene maintenance protocol. So I have to have a good prosthesis that will allow me to have high hygiene maintenance capability. And the dream is, of course, to have the lowest cost as possible for the patients so that more and more patients could afford from this kind of treatment. So then we go into science and we say what we have in terms of science publications. Till last year, we had more than 34 publications with novel biocare implants about the All-on-4. More than 2,600 patients treated. More than 10,400 implants placed. And we are not talking about 1 year, 2 years, 3 years follow-up, talking about 5, 10. And recently this year, I can tell you, we have published 2 major publications with 13 years follow-up of the maxilla until 18 years follow-up of the mandible. And I want to share with you these 2 publications. So for the maxilla, we got together 1,072 patients with 4,288 implants placed. And the implant cumulative success rate at 5 years was 97.7%, at 10 years, 95.6%, and 13 years, 93.9%. So you can see that the marginal bone loss at 5 years was 1.18 millimeters, and 10 years, 1.67. When we go into the mandible, where we have till 18 years of follow-up, we got together here 471 patients with 1,884 implants placed. So we can see the cumulative success rate at 10 years being 95.9%, at 13 years 93.5%, and 18 years 91.7%, with the marginal bone loss at 10 years 1.72 and at 15 years 2.32. So basically, taking all the science into consideration, and especially taking the needs and Clara into consideration, my treatment option was the All-on-4 standard. Now, I would love to see your answers. I would love to see if you agree with me with this treatment choice. So, Paulo.
Thank you. Thank you, Anna. Thank you very much. We do have the questions here, and I ask to project the questions on the main screen if possible, so that we have a look. 60% have voted on All-on-4 as the treatment of choice, and that's actually what Anna decided. 34% have decided on 6 implants. 34% is a lot of people. 2% on grafting with autologous bone, and actually 4% with grafting with biomaterials, 0 zygomatic implants. So I will call the next speaker now, and at the end we will discuss some of these results. So Glen, thank you very much, Anna.
Thank you.
Glen, the stage is yours.
Thank you.
Thank you, Paulo, and thank you for the pleasure of being here. Good afternoon. So my patient is John, and he is 82 years old. He's got arrhythmia, and he's got gastroesophageal reflux disease, and he's on warfarin, which is really the only significant medication that he's on. And he had he's been edentulous in the maxilla for decades, and he's had his recently, when I saw him, so about 6 months previously, he had the remainder of his lower dentition removed and an immediate complete lower denture. Socially, he lives quite remotely, and he's a pensioner, which means he doesn't have a lot of money. So you can see here his recent denture that was provided somewhere else, and he's also got a maxillary denture, which he's very happy with, and he's got a typical sort of relatively recently extracted lower arch. When we look at his OPG, he's got typically quite a lot of bone interforaminally, and resorbed bone in the posterior region after having lost his posterior teeth quite a number of years ago. And then the maxilla has a typical sort of combination syndrome type of appearance to it. We did the planning for various treatment options in DTX. So in John's situation, he can have 2 implants for a 2-implant overdenture. He can have a trefoil, he can have an all-on-4, and he can have 5 axial implants. He's unable to have any implants posteriorly. So my question to you at this point would be, what option would you choose for John? Would you choose 1, a 2-implant overdenture, 2, trefoil, 3, all-on-4, and 4, 5 implants for immediate fixed bridge? So while you're doing that, I'll give you a little bit of an overview of Edentualism. There are a lot of edentulous people worldwide. It's estimated at maybe 270-odd million people. That makes up roughly 20% of an industrialized country's population. Now, as we are living longer, those numbers are actually increasing. So the number of edentulous people that we're going to see is actually going to be on the increase. The terminal dentition, though, is massively underestimated, because this data is usually generated by phone surveys, and so you ring up someone and you say, have you got any teeth? And they say yes. You don't know whether their teeth are terrible or whether they're great. So we don't really know how many people have a terminal dentition, but it's large. And the journey to Edentualism is now happening much later, at a later age. You're no longer getting your teeth out in your 20s. It's happening much later, often in their 80s. Edentualism is linked with systemic disease, things like obesity, hypertension, obstructive sleep apnea, etc., etc. The edentulous state affects people's psychology, and so it changes their food selection as well. They tend to eat more processed foods and things that are not really that good for them. So that affects their health. We can provide dentures, and we have been doing for hundreds of years. But most denture wearers that get dentures when they're fairly young adapt and cope relatively well. However, as the person ages, it becomes much more difficult for the adaptability. It requires a level of neuroplasticity that both peripherally and centrally that makes it difficult for people to adapt to the denturous situation. So therefore, a lot of people suffer from chronic dysfunction, pain, low self-esteem, and it affects their oral health-related quality of life. As the edentulous person ages, their resorption, the ridge, reduces the denture support, and they get a progressive degeneration of the supporting tissues and their neuromuscular control. And so when some denture wearers that were adapted then become maladaptive with time. So we know that if we provide implants for a patient, and we either give them a fixed or a removable option, that compared to conventional dentures will improve their quality of life. It'll improve their nutritional state if they have some level of education along that lines, and that improves their health as well. So there's these various strategies for treatment of the edentulous jaw. You can have a complete denture, or you can have implant retained overdentures, or implant-supported fixed prostheses. Overdentures, if you compare them to complete dentures, have a better quality of life. Patients are reasonably satisfied with them. But all of these studies generally compare a currently edentulous person going to an overdenture, not terminal dentition patients, which is what most of us are dealing with these days. Overdentures have a lot more complications. They have more peri-implant mucosal disease because you've got an acidogenic environment, you've got low oxygen tension in the tissues, and so therefore the plaque becomes more concentrated and they have more problems with the peri-implant mucosa. The biggest problem that we as dentists find is the mechanical problems with wear and distortion of attachments and problems with coping with those sorts of things. And that can be very much a multiple thing, particularly with some patients. So you see some patients come in every month or two with my denture doesn't hold in place anymore. And so the literature is replete with the amount of maintenance that is required for overdentures. The other thing is that there is continual ridge resorption over the years. And this is a beautiful set of slides from George Zarb that show the amount of ridge resorption that happens over the lifespan of that person. So what happens is that then the mental foramen becomes more coronal, and so then you can get nerve compression, which leads to neuropathic pain. So then again, overdentures are not suitable for more resorbed ridges. And Andrew's got a fantastic case that shows that. If we compare fixed solutions to overdentures, then you get a particularly much more significantly improved function. Try that in English, I think. So you get significantly better function with a fixed solution than you do with an overdenture. You get a significantly higher level of overall satisfaction with fixed. And from a terminal dentition point of view, people that have a terminal dentition have still got basically relatively stable teeth. They may have caries, they may have periodontal disease and all the things that cause it to be terminal, but it's still more fixed than an overdenture is. And so they much prefer to have a fixed solution. And I think and the studies would tend to say that you get slightly better oral hygiene with overdentures. I would dispute that for the reasons I said before. However, the only one that I probably would agree with is if our nursing home patients. And so that ball attachment there, that's on a 94-year-old patient with dementia that's in a nursing home. And so obviously she's not the one cleaning her implant, an auxiliary staff is. And so that's easier to do if you have an overdenture. So if we go back to John, and we're talking about our different options, he's got enough bone for implants in all those different things, and he's got sufficiently good quality bone to have immediate loading. In fact, immediate loading for pretty much all of our implant cases is in the mandible is a given. So it's very rare that we don't immediately load our mandibles. In addition, he can have a trefoil, and this very nice study done by Franz Lambert's department was a CBC study of 100 mandibles, and they found that 85% of patients were able to have the trefoil option. And that fits in with our experience too, around about 60 patients that we've treated, in that you have a large range of demographic of patient that you can treat, from very tiny people to very tall people. They all seem to fit fairly well into the trefoil arrangement. If we look at some of the other aspects that we might think about when we're choosing an option, we've got to create a final bridge. So you need some appointments to create a final bridge. You need to do an impression. This is after healing and all that sort of thing, so it might be 6 months, a year, 2 years down the track. You take some impressions. You might do verification, jaw relations, try-in appointments. You've got to get a framework made, and then you've got the delivery of the prosthesis. It may take 6 appointments, it may take 3, but it's going to take some time to create that. Whereas a trefoil definitive bridge can be provided on the day of surgery. The cost to the clinician, if we're looking at trefoil, the hardware cost, like from Noble Biocare, is roughly 25% less than the cost of, say, All-on-4. There's no provisional bridge cost, and it takes roughly 1/3 of the clinical time to get that definitive bridge. So you're generally saving around about 4 hours or so. So when you add up all of that, in my country, it costs the patient roughly 50% less to get the same thing. That is a high-quality, well-fitting framework with an acrylic wraparound type of hybrid bridge. So, back to John. He had a preference for a fixed solution. He had limited funds and he lives remotely, lives about 500 kilometres away, which in Australia is only a walk, it's basically the corner shop, but it's a significant thing for him. So he chose the trefoil option in that it's going to be cheaper overall and it saves him significant time to attend appointments and get his definitive bridge. So the surgery, you may have seen that. You can have a look at all of that in the booths, is a particular type of surgery that places those implants in 3 positions. The surgical prosthetics, as I like to call it, is very simple. It takes roughly 15 minutes to do that. And then you've got some lab phases, which again are relatively simple. It's within the realms of pretty much any prosthetic technician. And the delivery of the bridge. And so that's what this looks like on the OPG at the time of delivery. And this is at the 4-year review. And there's been a sort of indiscernible loss of any bone around those implants. There's been some wear and tear of the restoration, as you would expect, over 4 years. And this is the typical sort of resorption of the tissues. So there is a bit of a space between the undersurface of the bridge. But he's happy with that because he can clean it very easily. We can, of course, reline it because it's a wraparound type of a bridge, but he's happy with that. Is it still up there? Okay. Then if we also have a look at his cleaning for now an 86-year-old is actually very good. And so this is why I say that I think a fixed solution is actually better for oral hygiene. And so the tissues are very healthy, and that's fairly typical in most of our patients. We spend a fair bit of time making sure that they can clean their bridge. The clinical time required in my practice, or from me, is roughly an hour to do the diagnostics. The diagnostics are the same whether I'm doing all-on-4, whether I'm doing a trefoil or even an overdenture. It still has that diagnostic workup. The surgery, I'm kind of slow. I'm a prosthodontist, so I'm sure there's some gun-ho oral surgeons that can do it much faster. But it takes me roughly about an hour and a bit to do the surgery and then about 15 minutes to do the surgical prosthetics. And then to deliver the bridge, which usually happens that day or possibly the next day, depending on how my lab is working, takes about 5 minutes. And then the other 25 minutes, I just sort of sit back and listen to the patient tell me how good I am. So roughly, it's around about 3 hours to do a trefoil procedure. If we look at in my practice, we've done, as I said, roughly 60, and we haven't lost any implants, and our prosthetic maintenance has been minimal to nothing for every patient. If we look at this multi-centre study that's been started, we're at roughly 2 years now, and there's been 110 patients with 6 implant failures and a prosthetic success rate of 99.1%. So it fits in pretty well with most of the standard types of procedures that we can do for the Edentulous mandible now. So, Paulo, we are back to the original question.
Yes, Glenn, thank you very much for your presentation.
Hey, I got close.
All right, so all-on-4 voted 43%, trefoil 32%. Actually, it's not too bad.
That's better than I thought.
Yeah, it's actually very, very good. Actually, very good. 2 implant overdenture, 21%.
Interesting.
Which it's also very interesting. And 5 implants with a fixed bridge, 4%.
So there's not too many entrepreneurs out there. They're all very altruistic.
Very, very traditional people here in the audience. Thank you, Glenn. Thank you very much. Now, I invite Enrico to present. Enrico is going to present maxilla, soft bone, which is always a difficult situation. Thank you, Enrico.
Thank you, Paulo. The job for this section, my job is to present you the rehabilitation of maxilla implant supported with so poor quality bone, an atrophic maxilla. When you treat this kind of patient, you need always to know everything of this patient. When you treat this compromised patient, you need to know the medical history of your patient, because may have effect on the quality, for example, of the bone. And this patient came in my clinic in 2009, 65 years old, and with high blood pressure and cholesterol. But also, and this is the main problem, he had a chronic low back pain, and this is controlled with the use of corticosteroid for a long time. The patient was no smoker patient, but odontophobic patient, and this is another important aspect to underline. Sergio chief complained about lack of aesthetic, unstable removable denture, and pain during masticatory function. When we treat this kind of patient, we always need to make an important backwork. We need to analyze our patient in terms of aesthetic, in terms of the face of our patient and the smile of our patient. When you do in a proper way this backwork, you will avoid a lot of mistake. So you need to have the end of the treatment of your patient clear in your mind. You need to know exactly where you need to place the two incisor in terms also of vertical dimension, occlusion, lip support. So always you need to give back dignity, aesthetic, not only function, to your patient. If you will see Sergio, you can see that we have correct vertical and horizontal facial proportion. We have a convex profile, but we don't have enough leaf support, so we have lack of leaf support. So we need to improve it during the provisional and final stages. Intraorally, you can see that we have failing dentition and prosthesis, and all means that we have failing aesthetic. What was proposed, what was offered to Sergio in 2009, an implant supported rehabilitation for both arches. During this section, I need to focus only on the maxilla. And when you see, when you understand exactly, when you study exactly systemic disease of your patient, everything about your patient, after this, you need to go more local. You need to make an analysis of the residual bone quantity. And so you need to know exactly the anatomical landmark of your patient. You need to see the sinus cavity, and you need to see if you have, like in this case, an important sinus pneumatization. When you see this, you see that there is not so much bone for Sergio to use. And it's important also to identify the quality of the bone, or to have an idea of the quality of the bone. In fact, when you make an analysis of the quality of the bone, the quality is important like as the quantity. In fact, when a patient have a chronic use of corticosteroid drugs, and from a long time a removable prosthesis from 15 years, all these things may have effect on the metabolism of the bone, cellular turnover, vascularization and mineralization of your patients. So always you need to consider all these important aspects, because you will meet during the surgery. For this maxilla, we have different treatment options. The first one will be the bone grafting for Sergio, and we can place 6, 8 straight implants with the related loading. Or we can treat using the residual bone with 6 implants with 2 short in posterior region. You can see the emergence of this implant, and you can see that there is a cantilever. Another possible option is to treat your patient with the Toronto Branomark rehabilitation. 4 straight implants in the premaxilla with immediate or delayed loading in relationship with the quality of the bone and the primal stability that you achieve. You can see also cantilever for this after the emergence of prosthetic screw. Last but not the least is the possible to treat a patient with the all-on-4 protocol. You see the emergence of the screw and immediate loading. You try to achieve immediate loading. Now, make your choice for this patient. My choice for this patient is an all-on-4 with extra long implant placed posteriorly for both arches. The advantages of this choice. When you use all-on-4 protocol, always you avoid to have demanding surgery. So you avoid to do bone grafting, sinus augmentation, 3D reconstruction of hard and soft tissue. And for Sergio, that is odontophobic patient, is in that time a great goal. Not only, you also reduce for Sergio the cost, about biological cost and also economical cost. Not only, what happened? You treat Sergio in a day. So Sergio came in my clinic with unstable removable denture and he gone away in the same day with fixed teeth and bridges. In this rehabilitation, I try to find more stability thanks to the length of the posterior implants. When you improve the length of your implant, you have many advantages. When obviously you have soft bone, otherwise you don't need to increase the length of your implant. When you use this kind of implant in the soft bone, you increase the area of contact between the tunite surface and the bone of the patient. When you use this long implant, you pass through more bone, you use more bone, and you enhancing the primary anchorage of your implants. Another important aspect that I try to achieve with my rehabilitation is to increase primal stability thanks to the lens, because I was touching the cortical layer of Sergio. In fact, you can see for the posterior tilted implants, 3 cortical engagement, 3 cortical anchorage. And so you can see I pass through the alveolar cortical, I touch the entire sinus wall, and also the angle of the nasal floor. For the entire implants, 2 bicortical anchorage. I pass through the alveolar cortical and I arrive near and touching the nose, the cortical of the nose. Another important advantage of the use of tilted implant, the all-on-4 configuration, is that we have more distance between the implants, and also we improve happy spread of our rehabilitation. Another advantage of this configuration is that we reduce drastically the posterior cantilever with all-on-4 rehabilitation than with the others. And also, the load is better distributed all over in the maxilla. These last 3 advantages is so important in terms of survival rate of our final restoration. I want to show you the surgery of Sergio. always, I want to stress this concept. Please, follow the protocol. The protocol is already described by Paulo Malo in 2005 for the maxilla and in 2003 for the mandible. Here you can see that the bone of Sergio was so soft. You can see the yellow aspect of the vestibular face of the maxilla. Not only. Thanks to the osteotomy action of the implants, you can see that the implant push outside the bone, and immediately you can see all over on the TU9 surface some yellow spot, also on the soft tissue. You can see this, and this means that we are matching with really fatty bone. And we cannot achieve planar stability if you don't use extra long implant, 20 millimeter Nobel Speedy Groovy, and you arrive near the canine pillar, that where you can find the best bone available in the mouth of Sergio, and also you touch all the cortical. Only in this way is possible to achieve primal stability for Sergio. And so we obtain the best goal as possible, immediate loading. In the day of the surgery, Sergio went away in this condition with function and aesthetic in the day of the surgery. 6 months later, we delivered for Sergio the final restoration. And always we start with a new impression and Facebook. We delivered this rehabilitation, not so high cost because he is Procera bar, titanium bar inside, and composite teeth. You can see Sergio after 3 years in 2012, stable, soft and hard tissue. At 6 years, stable, soft and hard tissue. After 9.5 years, we make a refresh, a renewal of the pink and white part of the rehabilitation. So we give again back to Sergio aesthetic also with composite teeth. Stable soft tissue also after 10 years, and hard tissue too. So what we can tell, that it's possible to treat this compromised patient with the so soft bone with protocol, all-on-4 protocol, and with the use of extra long implant in posterior region. Thank you.
Thank you, Enrico. Thank you very much. So now we will check your voting here. You chose all-on-4. Enrico, you are number 1. 83% on this case chose you. So this is really very good. And then the Toronto Branomark, which I don't know what this is. Oh yes, Toronto Branomark 4%. The 6 straight implants 8%, and the bone grafting 5%. Good. This is exactly this is what we expect for this type of presentation. So I will ask Andrew to come to the stage and present his atrophic mandibular. Thanks, Andrew.
Thank you, Paolo. And I think when you see my case, one thing we can agree on is that my implants will be shorter than Enrico's. So, you know, the atrophic mandible, I think we are so used to talking about the atrophic maxilla, but our patients are so compromised when they have an atrophic mandible, because that's the situation where they're going to be miserable with a removable denture. And this lady was miserable with her removable denture, particularly her lower denture, not surprisingly. You know, she found it hard to socialize, hard to get out. And what I'm asking you, what we're asking you today, is to tell us, what would you do? You know, we might think about an iliac crest graft. We might think about using biomaterials. I mean, we can grow bone anywhere now, can't we? I spend quite a lot of my time putting implants in people's fibulas. So when patients have had resections for cancer, the fibula will give a wonderful length of bone to replace missing tissue in the mandible. And actually, I had that discussion with this patient because whatever we did, maybe there was a risk of fracture of this very slender mandible. So we did discuss this. So what would you do with less than 5 millimeters of mandibular height in places? Would you graft? Would you graft with a biomaterial? Are we going to think about trefoil? Are we going to carry out an all-on-4? What would you do? Let's think for a moment about all-on-4 in the mandible. So, very often, the anterior mandible is obliquely, lingually inclined. So, our implants may be shorter than it appears that there's scope for them to be in a panoramic radiograph, for example. So our radiographic planning is so important. We must use 3D planning, and of course, we're using DTX routinely. My approach to treatment in an atrophic mandible might be rather different. So I love guided surgery. I'm very focused on using the benefits of digital technology when I can. So I've gone through a DTX planning. I've made a guide for this particular case, a different case. And I've fitted a guide. I've placed anchor pins. But actually, I'm going to remove the guide and make my incision where I want it to be, where there's just a small remnant of keratinized tissue left behind. So I'm taking off the guide, making my incision, laying a flap, and then replacing the guide so that I can do the surgery in a guided fashion, but with perfect control of the tissues. But you see, as you lose bone, as the mandible atrophies, the mental foramen relatively becomes more superficial. And the benefit of tilting the implant actually begins to reduce. So when we've got a good bone height, we can gain a lot of support, reduce our cantilevers. But if the mental foramen is very close to the crest, as we tilt the implant, the benefit is more limited. So what will we do in this case? And how are we going to go about our treatment? We must always start with excellent prosthodontic planning. That is key. And if we're going to bring our prostheses into our digital environment, into our virtual environment, then we need well-fitting prosthesis. And this is going to make all the difference later on when we come to our temporization and even our definitive stages. So, how are we going to achieve stability? And what can happen if we don't have a stable radiographic guide? So in this case, we have a highly atrophic ridge, rather like our patient. And what I want to show you here is that there's an airspace. And that airspace is very subtle. But what it's showing us is that the prosthesis is actually rotated. So we've taken the scan with our radiographic guide in the wrong place. And what that means is that if we go to surgery with a surgical guide based on this planning, it's going to be in the wrong place. And our treatment will be in the wrong place with potentially catastrophic consequences. So here, the implants would have been placed through the mental nerve. Disastrous. So we need excellent prosthetics. We've seen some tremendous innovations at this conference. It's been really exciting and enlightening. But let me show you something that's really old. This is composition wax. This is a perfect impression material for primary impressions. It's mucodisplacive, so actually we can extend our radiographic guide, our prosthesis, over the full bony platform. Probably overextended for a prosthesis, but for our radiographic template, perfect. So we go from the dentures to a try-in on wax, and then we use the wax try-in with a zinc oxide eugenol wash to achieve a perfect impression. And we can take that into our planning. You can see the genial tubercles sticking high above the ridge, and the prosthesis in place. Look how it's projecting beyond the lower border of the mandible. And you can really imagine why this patient experiences an unreasonable amount of discomfort with a prosthesis. You can see how it's directly on the inferior dental nerve. So, have you made your choices? What are we going to do? Well, you know, we really do want to avoid a graft, if at all possible. And trefoil for this lady, unfortunately, was not suitable because the shortest implants are 11.5 millimeters long. So, you know, we can't use trefoil, and I think it's a terrific, fantastic innovation, which has really made a lot of interesting things possible in our practice. We've talked about the all-on-4. And so really, I think our focus is on, well, 4 to 6 implants. But how many implants? You can see here a conical connection implant in place. We want that conical connection implant to be subcrestal. So our shortest conical connection implant is sticking out several millimeters beyond the inferior border of the mandible. Not ideal in this case, although I love conical connection implants. So how about a good old Branomark implant? Now, this sort of treatment has been going on for decades now with this implant. And this is what we elected to use. And actually, I'll jump to show you what that looks like. Slightly tilted, the most distal implant, using a Branomark implant. So we've gone to complete our planning, hoping to carry out guided surgery for this patient. And you can see that what we've selected to do here is to use 6 straight implants. And we're using 6 implants because this isn't about how many implants are there, but more about how many threads do we have in the bone. And actually, to get some kind of immediate stability, we wanted as many implant threads in the bone as possible. And we want to immediately load this, because otherwise we're going to have a denture that's moving around on our newly placed implants. Now, you can see this negative ridge. So hard to stabilize the denture. And actually, we decided that it was too unreliable even to stabilize a surgical guide. And as I've shown you, we want to put our incision where we want the incision to be. So we made a decision, in fact, to not use a surgical guide. We've prepared our incision exactly where we wanted it to be with a great deal of care, because we have the inferior dental nerve running across the ridge. And we've 3D printed a model so that we could study the inferior dental canal and see where we would find ourselves in reality. And now you can see that we're finding the canal, placing our implants. The arrow points to the groove through which the nerve runs, and actually we've gently lifted the nerve out of the way and placed long abutments. To my mind, as long as possible, to make it easier to clean, to make the prosthetic stages easier. we're picking up the position of the implants, taking a plaster of Paris impression, which is an extremely biocompatible material to be using at this time. It's rigid, it's a joy to work with, hemostatic. And you can see the temporary bridge in place, the long abutments and the design of the bridge favoring really good access for hygiene. The definitive work was beautiful. This is opposed by a similar bridge on zygomatic implants. But for me, I mean, this is the real excitement, but there's another level of excitement for me here, which is look what happens 3 years later. Take a look at the bone. It's hard to see, but there has been an increase in bone height behind the prosthesis. And let's look in a little more detail at the inferior border of the mandible. You can very clearly see, I think, that the implants start perforating the inferior border of the mandible, but with time, we see something extraordinary happen, which is the inferior border of the mandible actually grows. So we have full bone coverage of all the implants. So, what would you do? How well have I...
Now we're going to see if you performed well or not. You did not dance, so they don't like you or like you. You did not do well. You want to cry? There's an handkerchief. Okay, so 44% of you said all on 4. 20% said 4 to 6 implants straight. 27% said trefoil. Well done, Mr. Glen. 2% grafting with biomaterials. I think these people don't know what they're doing.
No. Well.
It's not possible to graft these kind of mandible with biomaterials. And 6% grafting with autologous. So when I see these, when we see these percentage and these answers, we immediately know that there's a lot of work on education to be done here. Good. So, last but not least, we asked Ruben to show you a case on atrophic maxilla. Thank you, Ruben.
Thank you very much to the organization. Andrew, you don't have a zygoma. Thank you. You don't have a zygoma in the mandible, so it's really difficult. Sometimes it's much more difficult to discuss on the atrophic mandible than on the atrophic maxilla. This is something. Okay, so we are going to finish the session with a presentation of a patient. This is Marta. Marta was 42 years old when she came to me 5 years ago, approximately. And to make a long history short, I would say that she lost all the teeth when she was around 20-something. She received implants some years later, but with the pass of the time and peri-implantitis, infections, and so on, she finally lost the implant. She was wearing a denture for years, and 1 year before she came to me, a maxillofacial team from another city tried a graft from the hip bone. She was taking care of the graft for nearly 1 year without a denture some periods of time, but finally, because of infection, resorption problems, she lost the graft as well. So she came to me in this situation. How is it? Sorry. She came to me in this situation. This is the X-ray. You can see in the CT scan that we don't have any bone at all at any level in the maxilla. And we have 2 cysts, big cysts, occupying the sinus, both cavities. And this is the intraoral view. So the complaints, the aims of Marta, of course, are very obvious. From the facial perspective, she wants to chew, She wants to chew again. She wants to rebuild the facial proportions, the vertical dimension, etc. She is willing, she would like to have an immediate loading protocol, obviously, because she has been suffering for such a long time. And we can use a conventional protocol to design a surgical guide and a provisional prosthesis, or we can use a full digital protocol, not totally perfect in the total edentulous patients, but sometimes we can, you can manage to use a printed surgical guide and a printed restoration before the surgery. But these are not the main complaints of Marta. Please look at this. This is 42 years old, 20 years edentulous patient with a denture, so she has important, deep psychological problems. She has a lot of problems with the self-esteem. And she has problems with the social perspective, with the work. She has problems at work. Remember, she has been without the denture working for some period of time. Imagine in Western countries, this is nearly impossible. This is a nightmare. And she has problems especially at the level of the intimate relationships. So what Marta wants, scientifically speaking, is an immediate normalization of the oral health-related quality of life. This is a scientific translation of Marta complaints and queries, demands, and the maintenance of the quality of life with the pass of the time. This is the goal of our treatments, and this is, of course, Marta's requirements. We have today three options. We have grafting with autologous bone, we have graftings with biomaterials, or we can use the quad zygoma protocol, the quad zygoma approach. So this is my question. Which is the option would you choose? Which is the best option for Marta? And I would like you to vote and to use this system. So what we did, first of all, was to plan the case. Of course, we opt for a quad zygoma approach. And what I'm going to do in the rest, in the remaining 10, 11 minutes, is to explain why we perform a quad zygoma approach in this case. Quad zygoma represents the possibility of placing 4 zygomatic implants, 4 well-distributed zygomatic implants, and to go for an immediate loading protocol the same day of the surgery of the first 24 hours. Before, we perform a functional endoscopic nasal surgery in order to clean the sinus. Remember, Marta had the sinus were with problems, so we saw many years ago that the main way, the fundamental way to avoid sinus complications with zygoma is to clean and to ventilate the sinus previously to the placement of the implant. And this is what we did. This is the surgery. There are many ways of doing the surgery. In the right side, we used this extra sinus approach. This was described especially by Paulo Malo. We allocate the implants at the level of the lateral wall of the maxilla. Of course, we insert the implants at the level of the zygoma, but we are not worried about the absence of a velar bone. The left side was performed by the extended sinus lift. It was published by James Shaw some years ago, and I like it very, very much because we can be out of the sinus in all the circumstances. We are modifying a little bit the anatomy, and in my experience, it worked very well. So, as soon as the implants are in place, as you see, we close the wound, we take the measures, and this is the result just some hours later. Of course, the central image is 1 month later, and this is the goal today. We want zygomatic implants on the crest or nearly the crest, surrounded by thick soft tissues in order to maintain the stability of this rehabilitation. And this is the immediate loading prosthesis. So look at these images. It is in Spanish, that's why I haven't, I don't have the voice. But is look at the eyes of Marta 3 months later. You know, this is the result. We are not treating the mouth of the people, we are treating lives. And this is fundamental, especially in this sort of patients. When she has been suffering such a long time, just 3 months later, everything is starting to change. And this is really important. This is the face of Marta. And of course, nobody discussed today that we can reveal the face of the patient, the profile of the patient, by means of a good prosthesis. This is something very obvious, and nobody discusses it. So why? Why we have chosen this technique? There are many extreme clinical circumstances. During the last years, 5 years, I have been to many parts of the world, in Australia, in China, well, many places. And I have always saying the same question. Do you have patients like those? Because sometimes many people discuss these patients even exist. So in all the parts of the world, they say, yes, of course. They are not very frequent. We don't know exactly the frequency, but we know that they exist. And many times they are wearing a denture. Nobody is doing anything because, of course, they are difficult patients. The first question we have to ask is bone reconstruction possible in this sort of patients? From the evidence-based perspective, it is possible to rebuild these patients. When you go to the literature, you can see that we have a low number of studies. Autologous bone seems to be the gold standard. We don't know the acceptance rates. We have to consider the morbidity at the donor side because many times we don't have enough with sources from the intraoral field. We have the problem of the bone resorption when subjected to loading. We have a prolonged treatment line. It's a long-lasting treatment. And this is not my words. This is Professor Curie's and Luca de Stavola words. It is often impossible to achieve an adequate internal and peripheral vascularization of the graft in large vertical reconstructions. So, is it possible to rebuild this maxilla by means of autologous bone? Maybe. There are very little studies on that, so we cannot be totally state that. Yesterday I was speaking to Lucas de Stavola, and he told me, no. Grafting procedures are for partial edentulism. For total edentulism, it's much more logical to go for graftless solution, extra-alveolar implants. He allowed me to say it. Look, are you here? So, and what about biomaterials? With biomaterials, we have the same problem because we have thousands of studies on biomaterials proving they work very well. But when it comes to the totally atrophied bones, the extreme circumstances, we have very little studies. We performed the first randomized clinical trial comparing zygomatic implants and biomaterials. We performed big sinus lifts together with two more groups in Italy. It took 3 years. It was a long study. And the conclusion was that, yes, it is possible to rebuild. It is possible to use big sinus lifts in this sort of patients. Grafting procedures worked, but it took 444 days, the average, to have an immediate functional loading of the patient, to have, because we waited 8 months after the implant, finally, more than 1 year, nearly 1 year and a half, the rehabilitation. But when it comes to the zygomatic implant, the situation is completely different. The evolution of the zygomatic implant has been a process of validation. Since the first publication in immediate loading, we have many studies using a two-stage approach, waiting 6 months, or with immediate loading. We have to consider that the vast majority of the studies we have today in the literature are with novel biocare implants. The extrasinus or extramaxillary approach has been described in order to be out of the crest and to try to minimize the sinus complications, the sinus potential complication. Look at this image. This is by courtesy of Chantal Malhevet. This is the James Chow technique, the standing sinus lift. And 1 year later, you see that the implant has been covered by the bone. The implant is incorporated by the lateral wall of the maxilla. It is the explanation, I think, because it is my opinion, it is not evidence-based, but it has many things to do with the long-term stability of the implant and the prognosis of this treatment. When it comes to the level of evidence of the quad zygoma properly, to summarize, with zygomatic implants, nobody discuss. It's much more than evident. We have long-term results. We know that the integration at the level of the zygomatic bone is very good and very stable. But what happened with the quad zygoma approach? We have different studies from Duarte, Brazil, from Chantal Malhevet. We have this prospective study we started in 2006, 13 years ago, very high survival rates, nearly 97%. And we have demonstrated, and for me it was very important, that the quality of life, the oral health-related quality of life, is normal in this sort of patients. It's normal, and it is maintained with the pass of the time. What I have to say is that if it was not normal, just better, it could be a palliative treatment. But if it is normal, it is a curative treatment. So our patients wearing quad zygoma protocol have the same oral health-related quality of life than the rest of the population. For me, as a medical doctor, it was very important to see this finding. Together with my friend Diane Feng from the 9th People Hospital in Shanghai, it's a great hospital, we did a meta-analysis on quad zygoma, and we saw that the survival rate was 97%, very limited surgical complications, and high patient satisfaction. So it is important as well. And remember this study I have told you, the first randomized clinical trial comparing zygomatic implants and biomaterials. To make a long history short, I would say that the conclusion of the study is that we have proven that zygomatic implants are a better rehabilitation modality for severely atrophic maxilla for many reasons, but the fundamental one is the time. We can rehabilitate the patients in 1.2 days versus 444 3 days. We have published in the clinics of North America, oral maxillofacial clinics of North America, just 1 month ago, together with Leslie Davis. And thank you, Leslie Davis, because she has done a very, very good work as well. And we have used the novel zygoma 45 degrees because, well, it's a new design, and we have found, together with 2 more groups from Lithuania, Simonas Bankauskas, and from Turkey, Dr. Doruk Kosigic, and we have found a 100% success rates. So, to end up, of course, I use the quad zygoma approach because it is safe, it is quick, it is predictable, it provides with an immediate normalization of the quality of life. So I think it is possible to say today that it is the first choice for this sort of patients. So thank you very much.
Thank you very much, Ruben. So we will check your voting. Yes, as expected. This is the type of case that we really do not have too many choices. 92% on the double zygoma bilateral, 5% grafting biomaterials. Again, you have to explain how can you do that. And 3% on autologous, which is okay, which is a good thing. So now, we have some questions from the audience. And what we will do now is I will place the questions to the panel from the audience that have been coming through my iPad. And then we still have time to discuss the voting, because this to me is very, very important. As I understand, and from the voting, we can easily understand that some people have not yet understood the concept of Edentulous. So we will go through and we ask the panel to discuss some of the voting, some of the answers. Okay, so the first question goes to Enrico, and the question is this: how to increase the primary stability in soft bone or immediate function or small volume of bone? Placing more implants, does it help?
No. In my opinion, it's important to have more bone than titanium in our rehabilitation. More vascularization, more bone. And so I want to use for my patient to increase the primary stability. When I have enough space, quantity of bone, I increase the length of the implant. When I don't have this, but maybe I have more crystal size, more space in terms of millimeter in the palatal vestibular diameter, what I achieve primary stability also thanks to the size of the implants. Now we have available in our pocket 5 millimeter RP Nobel Speedy Groovy implants. The tip of this implant is 2 millimeter, and this tip is less of the tip of the 4 millimeter implants. So you can achieve primary stability thanks to the fact you under-prepare a lot your bone. And so you improve thanks to the size and not thanks to the length. So you have different options to push your bone and to improve the stability of your implant and to achieve the goal to perform immediate loading.
Thank you, Enrico. Now I have a question for Ruben. Guided zygoma, is it possible?
Well, it's a very good question. Yes, of course it is possible, but the problem is that, well, there are many problems. The first one is that we have very little studies on superimposition. It is necessary to have, a comparison between the positioning, the planning, and the real position of the implants. We performed a study 10 years ago, where I remember with Chantal Maleve. We found, to summarize, that when you are sure that the radiological guide and the surgical guide are exactly in the same position, it can be very, very accurate, and it can be done. Okay, but when if zygomatic implants are indicated, normally the maxilla is very flat. So if you don't use something to fix the surgical guide and the radiological guide, it's impossible. So to summarize, yes, it can be done, but you have to design or see something to fix the radiological guide in the same position as the surgical guide. Okay?
Thank you. So
navigation is another thing. I think that the future is going to be more, on navigation.
So basically, it's possible, but we do have a problem with stabilizing the guide.
Yeah, exactly.
Thank you very much. Now we have a question for Anna. In Anna's case, 6 implants would be better because of the age of the patient. Anna, can you comment on that?
Yes. It has nothing to do with age. I think...
Maybe the patient is 6 years old, so 6 implants. 40 years old, 40 implants.
No. So it has nothing to do with age. So the thing is, I think I explained during the lecture that 2 of the main reasons why I could not use 6 implants. So by the time I do the clinical evaluation and I realize that I have to reduce the bone due to the smile line of the patient, due to the prosthetic space, then I don't have any more space available to place the 6 implants. If so, then I would have to go and grafting. But the reality of this is that we don't actually need 6 implants. In terms of biomechanic, to have a fixed bridge, you actually don't need the six implants because 4 are more than enough. The problem with the distribution of the forces are when you start to having forces on your cantilever, basically the majority of the forces are dissipating in the first 2 implants. So if you add 2 more implants in the middle, they will not basically act on the dissipation of the forces. So if you go into the biomechanical studies, 4 implants is enough, and it's not a matter of age.
Thank you, Anna.
Thank you.
Actually, we have exactly the same question for Andrew. And this is nice because people are thinking and asking. So this is 6 implants in a very atrophic mandible can weaken the atrophic mandible because, of course, we have more holes. So why did you do it? And in terms, it makes no sense in terms of biomechanics. Andrew.
So, in many ways, I couldn't agree more. You know, I would have preferred 4. I might have preferred 5. But the reality was that we weren't really counting implants. We were counting threads in bone. And as we moved away from the midline, the amount of thread in bone seriously reduced. Not only was it a negative ridge, but the mandible actually had a superior hollow, so it was concave on the surface. So I agree. I want 4 implants. I want 5 implants. I don't really want 6, but I do need good anchorage. So it was all about threads in bone. And perhaps if I had 4 really stable implants at the periphery, I might have felt differently. But for that case, we needed those threads. How do you feel, Paulo? How would you see that? Anna?
Hello? Yes. In the cases where I have these atrophic mandibles, actually, I usually only use the 4 implants. The thing, as you say, is many times we are dealing with very hard bone, and sometimes it's difficult to get a good stability because of very, very hard bone. So I think the secret always is to drill according to the type of bone that you have. And in many cases like this, I have to drill with a 3.8 drill to just place a 4 millimeter implant to give a good anchorage and not to overforce too much. That's what I feel.
It's so important, don't push a lot the mandibular bone, because you can introduce a fracture. So in the upper jaw, when you have soft bone, you can push a lot. In the lower jaw, it's mandatory to avoid push. So you don't need to under-prepare a lot. You need to arrive near the diameter of the implants, because it's so dangerous.
I also took a view that although I would usually try to be working in both arches simultaneously, for this particular patient I left her with a denture through a short healing period while we did the lower jaw, because I thought...
This is what actually I was going to ask you. Was this an immediate load case or not?
Immediate load.
Immediate load.
But with an upper denture, we waited before we did zygomas, because I wanted some feedback to help us.
This has actually, it's the case you presented. It's a typical situation that a lot of people are confronted with, and everybody's afraid. Everybody's afraid of handling these cases because they're afraid of breaking the mandible, and unfortunately, we do have some cases, a lot. And but again, I just want to emphasize that unconsciously, we tend to place more implants because we want more stability, but in fact, it's not true, because as Anna said, the biomechanical studies is that most of the force is on the implants on the end. And then the force on the implant after that one is actually going upwards. So we do not really need a good implant. The other implants actually play no force. But it is very typical, and I understand your situation here. So if it was like a full mandible like Glen, and if you place like 5 or 6, that would make no sense at all. But in a situation like yours, I understand that sometimes we have the rationale, we have the facts and the science, but then there's something that tells us, well, maybe I just put a little one here just to give a little bit more stability. So it's understandable. Glen, why not use guided surgery for the all-on-4 mandible and deliver the bridge faster?
Well, you could. You could do that. We have done that. I think there is there's a few aspects to guided surgery with the mandible, and actually Andrew covered that very well, in that you can't, well, I really don't like to do a punch technique, so a flapless surgery in the mandible, because then you lose what little keratinized tissue that you had. And you know, while there's a lot in this conference about talking about grafting soft tissue around you know, aesthetic implants, it's also equally important in the mandible too, because you often have very thin tissue, and that tissue is really very important for bone stability. So you then have to then raise a flap and then take the you know, the template on and off. You could also, like you say, create a final bridge on that, but I don't believe that the accuracy is anywhere close to what the accuracy is for like a Procera bridge or a trefoil bridge. You may be able to get something on there and crank it on, but there's no way that you're going to get the level of passivity from a guided bridge over a full arch.
Thank you, Glen. Ruben, you want to comment?
1 minute to add. I agree with you. You know, the philosophy of trefoil was initially to be disconnected to new technologies, to have the possibility of providing with a fixed bridge with a structure in the center of Manhattan and in a small village in India, you know, with a very good result. Mm-hmm. This is one thing. And the second thing is that it was surprising to see that trefoil is more accurate than guided surgery. And this is something surprising, because we have the maximum is 0.5 millimeters of discrepancy, and with guided surgery in the mandible, you know it perfectly, when you have very big resorption, you are not accurate at all. It's very difficult to have accuracy. So with trefoil, we can be very, very accurate. It's 0.5 millimeters, the maximum, summarizing.
Sorry, yes. I mean, if we look at trefoil, the whole point is to keep it simple, as Ruben said, but if you want to make it more complicated, why not guide the trefoil? Guide the first drill hole, put the middle implants in exactly the right place, and make it super easy, super accurate. So if you're going to get complicated and you want to stay with the trefoil concept, guide that.
Good. Thank you, guys. Yes. This was very good. Sorry, Ruben. This was very good. We still have 7 minutes, which is great. Thank you very much, because you're really good on precise timing. And it was really nice, this interaction with the public, asking the questions and voting, because it gives us a lot of information here. But because we do have 7 minutes, I would ask Joanne to place on the screen the voting, so each of you will just comment quickly. 7 minutes, we have like 1 minute each to comment on the voting. So we have the voting here for Anna, and Anna, we have 60% all on 4, which is pretty good, but we have 34% on 6 implants. So
yes. So as I commented before, these 34% I think are totally understandable when you don't take into consideration the clinical situation of the patient. When you start to evaluate that you don't have space available, that actually have to reduce bone, then these 6 implants don't make any sense anymore.
Yeah, and also to place 6 implants, you need to have space to place 6 implants. Because sometimes the all on 4 is when we do not have time or space for 6 implants. Yes. So the next one was, Johan, please. Glen, you got 43% on all on 4, 30% on trefoil, but you got 23% on overdentures. So please comment on this voting.
Well, I think that it's an interesting comment, and overdentures are very popular in a lot of parts of the world. And let's face it, out of those four options, there's no wrong answer. Where I see overdentures is we have done some long-term studies on a single implant overdenture, which has given very high levels of satisfaction, and that works at a very low price. Once you start to get to 2 implants or more implants for an overdenture, then I think that trefoil is actually a better one to upgrade to. And the difference in cost is actually not as much as what you think. So therefore, I'm kind of more thinking of trefoil as an upgrade from an overdenture than say, a replacement for all-on-4 or something more customized. So that's how I think about it anyway.
Thank you, Glenn. My question here, and what raised me a little bit of attention, was that 23% of people with a mandible full of bone, easy to do trefoil, all-on-4, 5, 6 implants, whatever, 23% of these people said overdenture. You know, so this is, which means that we have not yet reached that level for people to understand that fixed bridge is better than a removable bridge. This is the message. All right, so now next would be
Enrico.
Johan? Enrico. So Enrico, in fact, I have no questions for you, Enrico, because 83% all-on-4.
So I don't want to comment anything.
So Enrico, you know, this is typical situation, 7%, 6 implants, a little bit the same, so there's not so much comment here. Next one. Andrew. Andrew, you have here 22% 4 to 6 implants, which was what you chose. You have 45% all-on-4 and 25% trefoil. Now, I need a comment from you on these two.
Well, let's start with the easy ones.
Yeah.
Trefoil simply isn't an option because we had less than 5 millimeters of bone in places, and the trefoil implant, the shortest implant, is 11.5 millimeters long. So not an option. Autologous grafting, maybe 15 years ago, 20 years ago, I could see some rationale for that. Now I would look at it as a last resort, and clearly we didn't need a last resort. Biomaterials, absolutely not. I don't know how everyone else feels, but for me, Paulo, would you do that? Would you think of it, Enrico?
I don't think without Photoshop you cannot do that with biomaterials.
I mean, I wish there was an opportunity for more questions. I'd be interested to see what the overdenture question would have elicited here. All-on-4. Well, yes, I would, if I felt like it would have achieved a result. But I think, to be clear, in the planning, if I was to place 4 implants, they would have been much closer towards the midline, because as I went further out, the bone was getting worse and worse. So I don't know, I felt like I was providing stability for a temporary prosthesis, and I think a temporary prosthesis was terribly important. It wasn't challenging to have immediate loading. It would have been challenging not to have immediate loading, and not, well, you couldn't get the patient to not wear a denture, and a denture would have destroyed the implants, I think.
I would like to see the questions if there was the option of overdenture on this specific. I believe overdenture here, if overdenture with you, was it with you? Yes. Was so much, I guess that overdenture with you, Andrew, would be like 80% here in this case, according to what we have. Ruben, you know, Ruben and Enrico, it's almost there's no question. There's no.
Sorry, Paulo, for the Andrew case, is mandatory to tell that it's impossible to rehabilitate this patient with overdenture, because you need to have implant-supported rehabilitation. Because if you have hybrid rehabilitation, every time the patient bites, you have pain. So overdenture is something that you cannot do in this case.
Yeah. Ruben.
Yes.
I do not have too many questions with you here, because it's, you know, it's such a limited case that we do not have too many questions. But grafting with biomaterials, 6%.
Yes, grafting of biomaterials, we prove in the randomized clinical trial that it is possible, but it takes 1.5 years. This is the difference. So graftless solution provide the same result, but in 1 day. So you explain this to 15 years old children, and they say, of course, it makes a big difference to have the result in 1 day or 400 days.
What I'm concerned is that grafting with autologous, which is the classic approach to a situation like this, was only 3%, half of that. So people do not feel comfortable in removing bone from the hip to place there, which we know we have good results in the past. But
the thing is, well, in this particular case, I have explained that the graft has failed previously. So it's very obvious. Zygomatic implants 25 years ago were described to this situation, okay? The question is, in a naive patient with no grafting previous, I think that the first choice, and I have proven that the first choice is quad zygoma as well, for so many reasons. Autologous bone, I think in the maxillofacial community as well, that, you know, everybody's seeing after 20 years that, of course, it is not as predictable as we thought. Of course, it can be very good in good hands, but it is not as predictable. We have problems when loading with the pass of the time. Of course, it demands a lot of compliance from the patient. It's 1 year, and the patient, Marta, this patient was without the denture for 6 months. Can you imagine? You are 42 years old. Marta was 42. It's a drama. It's absolutely. So I think that the dental maxillofacial community is starting to understand that in total edentulism, it's all about quality of life. We are not treating teeth, we are treating the person with a lot of complex situations. And this is something important.
Thank you, Ruben. Thank you, everyone. We have the last slide here. These are the patients that were treated today with the help of our experts. The options were all explained. I hope that with all these options and the reasons, because the reason we made this specific lecture or session was exactly to make it interactive so that you can see what options they are, but most important, the rationale behind these options. Because sometimes we get answers like, in the case of Andrew, biomaterials. How do you use biomaterials to increase the volume, especially in height of a mandible, you know? So I hope that this will at least make you think in the next days of the options we have on these types of complex cases. And again, thank you very much. Thank you, the panel, and continuation of a great Congress.